Hi, everybody. Welcome to episode number 38 of Tough to Treat. In this episode, Susan and I discuss a patient of mine who came in to see me with an initial complaint of medial and lateral elbow pain. And that's what she had many months ago. And fairly typical patients who have elbow pain, they wait and wait and wait. And then they come to see you and there's like a whole other diagnosis going on, which is what happened with her. When I saw her, I was the third physical therapist that she had consulted, and she had full-blown arm pain, in addition to the bilateral and the medial and lateral elbow pain, full-blown arm pain and extending into the hand, which she also described as a stickiness. She wanted to take the skin off, to quote her. Not a really common presentation with elbow pain. So join Susan and myself as we discuss and clinically reason through my assessment and talk about future treatment. So we hope you enjoy it, and we really, once again, want to thank all of our listeners. We had a really wonderful 2018, and we're going to start to change things up a bit in 2019. Every so often, we're going to have a listener on to discuss a tough to treat or complex patient that they are trying to sort through. So if anybody wants to get on board, we're going to do this maybe once a quarter, once every couple months. If you want to get on board and discuss a patient of yours, please feel free to email us or contact us on social media. All right. Thanks a lot and enjoy the episode. Hi, everybody. This is Erica Mello, and I'm with my co-host, Susan Clinton, and we are Tough to Treat, and Happy New Year if you're listening to this in January of 2019. How are you, Susan?
I am well, Erica. How are you? Happy New Year to you.
I am good.
This is coming to everybody. I'm out west for a 2-week run. I'm teaching out west and visiting my daughter in Arizona. So I am away from the rain and the funky weather in the east, but, a little brisk and a little cool out here in Arizona, but the sun does shine, so that's always a positive in January for me.
I know. January is not one of my favorite months. I mean, it's a month for me to cocoon and things like that, but it's the month goes by very fast, and it gets very bleary and dreary here in New York. And I'm looking for a massive snowstorm personally, because that's when I'll really feel like it's winter. So it's raining and foggy here. But we have an interesting patient today. I'm going to get right to it, if that's okay.
Okay. Yeah, let's do it.
Yeah, she is somebody that I just started seeing literally right before the holidays. So I was her third PT. So just a quick background on her, because I'm still treating her. I think I'm seeing her today. She's 51 years old. She came in initially with complaints of right medial and lateral elbow pain, typical epicondylitis, medial and lateral. And her secondary complaint at the time I saw her was that her right arm was sort of swollen. It was achy. She would constantly want to rub it. She felt it was quite stiff. And her prior history, just quickly, was she felt that the symptoms began in the spring and summer of 2018 when she's in the financial industry, but she at home at night, she literally holds her phone and reads from it. I'm like, who reads from phones anymore? But she was reading from her phone, and that's when the right medial elbow pain started. I'm assuming she's had the smartphone, and that's when it began. And once again, with people who have these problems, especially elbow pain, the consumer will, it'll get better, and wait, and it doesn't get better. And I personally had this experience, so it doesn't, you need to have some intervention. So she waited and didn't get better. She saw a doctor I think at the end of the summer. So she waited probably about 4 or 5 weeks, and he took an x-ray and diagnosed her with some, quote unquote tendonitis, which always kills me because you can't visualize tendons on x-rays. But anyway, he gave her a referral for physical therapy, where they did a lot of probably your typical, elbow pain exercises and gripping and extension and resisted things. That's what I guessed. She didn't really tell me what they were doing.
She didn't get any relief at all, and she stopped. And it started to get worse and worse in the fall. So she ended up seeing another physical therapist who she knew, who worked with runners. She's a runner, and he had worked a lot with her, trying to get her back running for an injury she had. She had a stress fracture, actually an actual fracture of her tibial plateau, probably a couple years ago, and she remembered him. So she went back to him, and he started doing cupping and the FRC and all these newfound things that PTs want to do for some reason. And it made it, I'm just going to say, get on my soapbox for 30 seconds. Okay, we're trying to distinguish ourselves as a profession, and if we start doing the cupping and there's all the thing, the FRC, and no one's going to know what the heck we do. No wonder people think, well, if this person does cupping, I can go to my acupuncturist because they do acupuncture and the PT does it, and then we can do this funky functional release technique, and I can go to see my massage therapist. We are physical therapists. We need to distinguish ourselves with our clinical reasoning process, people. Anyway, I'm going to get off my soapbox, but so she got worse, of course, right? And her arm was getting worse. She was getting more. This is when the whole arm involvement started. I think when she started to work, when he was doing a lot of these sort of cupping and a lot of just moving the arm around, and it just was not making her feel better. She ended up seeing another physician here in New York who did another x-ray. Nothing really, there, and then put her on diclofenac. Okay, so that's when she ended up in my office. So, past medical history, well, she's a runner. She also cooks a lot, which is quite interesting. She uses her arms. And the only other thing of note was she had a stress fracture in her tibia. Actually, it was a stress fracture. She was immobilized, and she was immobilized way, way, way too long and too much. And she ended up getting a DVT.
Oh, my goodness gracious. Wow.
Yeah. Had a PE and everything. No, from a stress fracture. Is that crazy?
Yeah.
So
that is crazy.
Yep. So I'm like, okay, well, geez, you've been through a lot. So the most aggravating movement for her, she is right-handed, and she's 51 and works at financial services, has 2 screens in front of her, is really moving her arm in open chain work, writing. I'm just doing this, writing, moving her arm in certain ways, like rotary movements. Gripping, of course, bothered her. She was worse in the morning. She slept on her side. And her basically, I look at her sort of the motions or the meaningful task that bothered her the most. And it was this sort of, her arm was about 45 degrees abducted in the scapular plane. I'm just doing this now. And she was doing elbow extension, elbow flexion, almost like wiping and cleaning a table. That's what bothered her the most. Okay?
What side did she sleep on?
Both sides.
So it didn't matter which side, she just
didn't bother her
had
at night.
Trouble at nighttime, no matter what.
It didn't bother her at night. It didn't bother her at night. It was worse in the morning, so maybe but it didn't wake her up at night. Her whole arm, she would do like this. She would take her arm from her shoulder, palm up all the way down, and say it's tight, it's swollen, and she would want to rub the arm. Okay, and that was her main issue when I saw her, which started as a simple medial epicondylitis, turned into a whole full blown, arm thing. So based on, I'm going to get your thoughts before I go into the objective. I mean, I had my thoughts. As I say, I think we make a hypothesis based on the patient's subjective. What do you think, based on what I've said, is her issue? And once again, I've only seen her a few times.
Yeah, it's very interesting talking about medial sided arm pain. I'm really glad we're doing this today because it's one of those things that I look at and it's like, what does medial epicondylitis mean anyway?
Yep.
Is it really medial epicondylitis? Is it dermatomal? Is it one side versus the other? And the presentation she's presenting isn't typical of a tendinitis or even a tendinosis. And especially with somebody who is like really super busy at the computer, you almost would expect it to be on the opposite side of the arm, and be that, kind of C5,
Well, she
extensor kind of thing. And,
she does have lateral. It started off as medial, now she has both bilateral,
right.
medial and
But
lateral.
now it's spreading, right? So,
Yes.
is it brain smudging, or is it something that was more centrally directed in the first place that just happened to be growing arms and legs now, which is very interesting. So the first thing, of course, that I'm thinking of, especially with the swelling, is I'm taking a step back and going, okay, what's going on neural tension wise? What's going on from the source? Is it brachial plexus? Is it the cervical spine, kind of issue, neural tension, from up there? Is it, something that is actually really driving autonomic dysfunction through the arm with the swelling? And, the other piece that I'm starting to think about here a little bit is, is she moving into kind of what we consider a full-blown, CRPS, chronic regional pain syndrome type issue, which, everybody thinks it always happens at the hand, but it can happen anywhere. Yeah. And or is it just more of a upper quarter kind of myofascial regional kind of stuff? And so then we kind of have to start thinking about, wow, what is the T-spine contribution to this, and the scapula and the shoulder itself, especially with brachial plexus. So those are kind of the thoughts I'm thinking is, I know she's really sensitive and tender in these places in her arm, because that's what she's complaining about, and those movements get her, and I totally understand that. But is that the culprit, or is that just the the magnifier there at this point? So that's kind of where I'm headed.
Yeah, no, I would I actually would agree, and that's what I was thinking. And so I took a look at her in sitting, in standing and sitting, and it's the main things. I won't go into everything. The main things that I did see just from a postural standpoint were, her right humeral head, a la Sarman, was anteriorly medially rotated, classic right-handed, nothing, excuse me, crazy. Scapula in a downwardly rotated. Once again, nothing that's not out of the ordinary. But what I did see, her upper to middle ribs, like 4, 5, 6, 7 in her. So she basically had in the front. So I have my hands palpating the ribs in the front. They were really left translated, right rotated.
Wow.
Not sure why, but that was pretty consistent, and that was the big thing. So I literally, she was sitting on the plinth. I put my hands right on top of her, right below the clavicle, and I felt like this big, on her left side, more of a fullness. I went into the axilla and palpated and went down, and she was really left shifted, right rotated. May not be relevant, maybe, and that was really, those are the two main things. The left clavicle was up. I mean, it's just the whole sort of compensatory twist. She had some things in her head, her right around where her C7, right where it sort of meets, where the upper traps are. It was like really compressed. So I always say in my biomechanical terms, a little bit translated to the right, but it was more compression on the right, and sort of, so C7 to the right, and then this right humeral head immediately rotated, anterior, more compression into that right brachial plexus, and the upper thoracic sort of shifted left, rotated right, maybe compensatory. Anyway, that's what I found in sitting. So I did a quick in sitting ulnar nerve screen, and that was positive. Okay, so that, I just had her do the hand, the sort of the typical one where you go above your eyes and you flip your hands are in an O, your thumb and middle index finger in an O, and you flip that up. That was positive.
Median nerve, man.
Exactly. Median nerve was really not. She was tight, but that's not uncommon. And then her radial nerve was also positive. The biggest thing was the ulnar, I thought. So that's what I did just quickly, because I had a funny feeling it was something brachial plexus, neural tension related. And then I said, let's just do your movement. Like, I didn't do the resisted test, extension, flexion. I'm like, what's it going to tell me at this point? It's not going to tell me anything that I don't already know. And I could have done that. I just did not. And so I had her literally put her arm in the position in her we'll call it her meaningful position. And I had her go in and out, elbow extension, elbow flexion. So I said, and I watched her. So the minute she put her arm up and to sort of open chain, like, the upper traps went up, the scapular elevated, the glenohumeral joint went more anterior, medially rotated, and it really bothered her. So I said, okay, I'll do the a la Sarman and Diane and LJ Lee. I went in and I corrected things that I felt may have been contributing to her problem. So I went in and I supported her scapula. Yes, the scapula should elevate when you lift your arm up. It's supposed to. But she had so much compression in there. So I went in under the arm. I unloaded the shoulder just to give it some support to take the pressure off. I had her do the motion again, made it worse. And I'm like, oh, geez. I didn't think that was going to make it worse.
Yeah.
I was like, okay, let's
Here
move
we go.
on. Exactly. So then I went in.
But before you go any further, I just want to point out is that I think the reasoning that we're trying to get to when we talk about some of these cases like this that have been ongoing for so long, when you talk about I'm not doing this test, I'm not doing that test, I think it's really important for everybody to understand that one of the driving factors behind it is you flare somebody up right in the beginning, you've lost the entire time for the eval. Yep. Because you already know it's going to flare. She's already told you what bothers her and what flares her up. So why would you take her through and do that at that point?
Right.
That's something for down the road, yes, but does that have to be done today? Probably not. Not if you're trying to take 3 steps back and chase down the reasons why she's hurting instead of, oh, well, I know I can flare up and this is this. So that's the approach that the other ones did that didn't really get you anywhere.
Yep.
So when you have somebody who's complex in front of you, you have to really kind of take a step back and go, if my goal is not to flare them up, but to try to find what's familiar to them, then I sometimes need to back off of some of these tests. So,
right.
Yeah.
Yes, that's a very good point.
Because you would have missed this whole piece
Yep.
had you flared her up.
Oh, exactly.
Yeah.
I agree. I totally agree. And I think that especially because she's been to, I'm her 3rd physical therapist, as you go, as you progress in your career, you can make these decisions. However, patients are very discerning, and you don't want them walking out of your office with, just another typical eval, and patients want to be heard. I forgot the book. They hear what they hear. They want to be heard. They want to be listened to. They want to be felt, literally. And I think that providing another way of looking at the body is a great way to do that. Yes, if the person just walked in your office and had an acute ankle sprain, okay, that's a different story. But the thrust of our podcast and why we're trying to get this across is that you have to use some clinical expertise here and make an executive decision at the time with the knowledge that you have. So
absolutely.
So, okay. So the scapular correction made her worse. And then I went in and I sort of tried to reposition her glenohumeral joint, a la Shirley, right? Shirley Sarman. Went in, had her do her whole, I called it the in and out maneuver. So, trying to move her arm, trying to clean the table, so to speak. And so once again, arm 45 degrees abduction, scapular plane, elbow extension, elbow flexion. That actually made her feel pretty good. So I said, I'm going to, because at that point, I didn't really want to start having her repeat the same movement that was bothering her. So I just went with that from that was the first visit. Okay. I took a while to listen to her history, and because I had the positive ulnar nerve, the positive the radial nerve, and then I ended up trying to, reposition the glenohumeral joint. Did it take tension off of the nerve? Yeah, probably. My hypothesis at the end of all that was she had some neural tension with, a secondary mechanical issue at the shoulder and elbow with it. Because when someone starts telling you they're stiff and they're scraping their arm and they're tight and they're gripping, that's not normal. Tennis elbow.
Neurological, yeah.
Exactly.
Definitely neurological.
Yeah, shoulder range of motion full, normal, no hand behind back, everything normal. Completely normal, not really hypermobile, pretty sort of standard mobility. So I'm just going to move forward because I'm treating her now. And so what I did was I gave her some nerve glides to do, okay, on the first visit. Some basic sort of, as David Butler likes to say, for the radial nerve, like the tip, the backhanded tip one that he uses. I gave her some ulnar nerves with like a towel, very sort of classic neural glides. And then I ended up taping her glenohumeral joint into a posterior position.
We're going to get questions about this, Erica, so I'm going to just interrupt you for a minute.
Yes.
When you're talking about the very typical neural glide exercises that you do with the, the waiter, like the, hand carrying the tray, and the, hand behind your back, like here, give me a backwards tip, and some of the other things that you're talking about. One of the questions that we get a lot on the, from our podcast is, what does that mean, neural glides, and what do you do, and what are your parameters? And so, can you just speak a little bit about? Did you have her go up and through symptoms? Did you not? How did you guide her? Because this is somebody who's going to keep moving and keep doing, and has not gotten better with other things. So it'd be kind of nice to hear kind of how you couched up that session for her, so that when she went home, she had some pretty clear ways to move that she wasn't doing before.
Yeah. So with the radial, I ended up I had her in that sort of waiter's position with the hand above the head in wrist extension. It's if you look it up online, it's like sort of, you make the fist and you bring the hand behind the back. So I had her so she's right-handed. I had her turn her head to the right, okay, and she would bend her elbow, straighten her elbow with the wrist within a wrist flexed, hand grip position, and had her elbow extend, elbow flex, looking towards her. Yes, she had some symptoms. When the elbow was straight, elbow flexed, took it off. I was okay with that. This is like 6 months already. So I was happy to have her push into symptoms. I had her do that like 10 times, like every 3 hours, I really did. And I wanted her to just continue to do it in the shower, do it when you're sitting. We need to mobilize the nerve. And so that's what I did. Every few hours, 3 times 10, or 10 reps every few hours. I said, if you can't do it every few hours, do it in the shower like 15 times, do it throughout the day, 15 times at the end of the day. So I didn't really, that's how I prescribed it. I didn't tell her. She's like, well, if I do a lot of them, will it make it worse? I said, no, it'll actually probably make it better.
Right, because nerves are bloodsuckers, right?
Right. I said, that's why in the morning you feel lousy, because you're not moving.
Exactly. And so that ties back into the whole history piece.
Yes.
Is it because she was laying on her shoulder or not laying on her shoulder, or how she was positioned? That may have had something to do with it.
True.
This got set up for some reason. There's a reason the nerve got angry.
Yes.
But the other piece is that, what does morning pain mean?
Right. Right.
She's, she's 51. She's old enough to be stiff, but she wasn't complaining of knee pain and, I'm stiff all over and my spine getting up. So it didn't sound degenerative.
No.
It just sounded like, wow, as soon as get up, it was hard.
Yeah.
And so you actually gave her something to actually do when she got up in the morning at her worst time. So
yeah. And then with the ulnar glides, very similar. I literally had her, because her prescription from the physician was like rotator cuff tendinopathy with the obvious epicondylitis. She had full shoulder range of motion. She wasn't complaining of shoulder pain. So I had her with her right arm and her left arm behind her back with a towel in between doing those ulnar glides. Same prescription. That would be a little bit harder for her with the towel, but she did it. Same thing, 3 sets, 10 every few hours, just more volume. Okay. And she did do that. And then I taped her, as I said, into a posterior glide. That's what I did the first visit. I explained to her that I felt it was neural based, not like, she didn't have any pins and needles or numbness, no really major weakness. But I explained to her the whole theory of how nerves, are bloodsuckers, the tissue gets ramped up. At this point in your journey, this is what I'm seeing. She didn't have this at the beginning. So I think her system got so sensitized. And I do think I think it is brachial plexus. So that's what I did. And I ended up, so that was the first visit. And this was written, then I saw her for one more visit before she went away for Christmas. And she said the shoulder taping helped her quite a bit. But she was doing a lot of shopping on the weekend, where she put her hand out as if to move hangers for clothes she was buying gifts.
Yeah,
that's the whole thing that set her off again. And I was like, oh no.
Same movement, yeah.
So I said, did you do your glide? She said yes. And she felt better. The taping was helpful. So this treatment, I did a lot of just sort of similar neural glide positions in sitting. And I can, I'm sitting next to her. It's her right arm. I'm just doing a lot of just manual gliding, things like that, of the radial and ulnar nerve. I did go into her neck this time, just because she had complained of some neck issues that day, and I didn't find a lot, to be honest. I found this congestion in the clavipectoral fascia, also supraclavicular, a fullness there, a fullness that I didn't see on the other side, which indicates to me there's some C7T1, maybe first rib, who knows, but it was definitely congested. I did some release to her scalenes, and then I ended up doing some mobilization with movement, into elbow extension, elbow flexion, like a radial nerve, like a glide, basically in there. And I just had my hands really just stabilizing her shoulder. I just called it mobilization with movement, but my web space was just in under, like, on her C7, and she was just mobilizing herself. That's what I did with her that first visit. Taped her again. She went away for the holidays, and she has nieces and nephews, and she came back right before New Year's. Actually, I saw her, and she said she was generally better, and she was lifting the kids. I'm like, oh, lifting kids. She felt okay. It's interesting. I'm finding that with her, the movements that make her worse are the non-resisted open chain movements, where when she has resistance, she doesn't really, it doesn't bother her so much, which I find very interesting. I did a very similar treatment. I didn't tape her this time because she had been away, and the tape, I don't think it helped her as much this time, even though she was better than the first time. So I did not do that the third visit. And it's similar. I ended up trying to do some nerve glides, closed chain against the wall, where your person's standing sideways to the wall, their hands on the wall, right? And then they're doing like a little bit of a, not a push-up, but elbow extension, elbow flexion against the wall, just to see if she could do that. And I felt she needed to have some closed chain position. I'm not sure what your thoughts are. She had a hard time doing that, actually. It was very weak for her. She did it no problem on her other side. I'm like, well, that's not surprising. I don't know what you think about that, because I felt that the nerve glides were good and she's doing them, but I need to move on. I need to progress.
Right. And well, I mean, but I think that's the progression is, closed chain, like make the distal side. The question is how could you have positioned her so that she wasn't in full out wrist, 100 the full 90 degrees of extension at the wrist, with compression with the body weight on there, because that takes the nerve and pulls it into a whole distal kind of thing, and then can they move over and back and front. I think you had a patient we talked about like this, that was actually the first place where you found the neural tension, when you got them on their hands and knees, or they were, in closed chain, and you got underneath their pectoralis, and it was like, I think I remember stating in that podcast going, oh, you found a neural tension problem, didn't you?
That's
but you had to wind them up so much to get there, and she is having trouble in open chain with just the simple movements, so, and I think that's probably why that popped in so much. But, I just want to go back to one thing so that everybody can kind of keep it in mind. There's some autonomic dysfunction going on with her too.
That's
why the swelling and the kind of just that whole feeling of bogginess and those things you were describing. And so compression doesn't surprise me at all that she had trouble with it. Because I'm kind of thinking, oh, what else is were we pulling in some of the other systems now?
Yes,
I actually got some blood flow going, which is great, and things are starting to change a little bit. But can the tissue operate under compression?
Right.
So.
Right. Yeah, no, I agree with you. I mean, she was severely compressed on that right side. And I did think, I am like totally about the thorax, and I do agree with you about the autonomic. I totally agree. And that's where I'm going to go today, actually, when I see her. But because nerves are, it's up and down, up and down. Sometimes they're good, sometimes they're bad.
Right.
So the last time I saw her, she said her neck was really sore after the last visit. I'm like, the neck. I'm like, the neck. What happened? And I'm like, here we go. Other than that, and she had a really, really bad cold. There's a flu going around New York. She was really,
coughing and
Yes. So her whole body was very sore, but she said the
Mhm.
nerve glides were helping her. She has more mobility, et cetera, et cetera. I did a typical treatment. This time I actually got her on her left side, right arm laying on pillows, and I was sort of working the I was trying to do I went back to my suprascapular nerve. I went into the whole nerves. I wanted
Mhm.
to see where a lot of them were positioned, where they referred to. So I got her on her side, and because I felt that I was doing still the radial nerve glides and the ulnar nerve glides and progressing those myself, just with flushing the tissue out. But I wanted to get her on her side and just try to release some of the superficial nerves. There's like suprascapular nerve, and there's a release technique that I learned in a course some years ago. You're on your left side. Well, because it was her right side that was involved, and she was just resting her right arm on a pillow, and I was just literally just sort of scap depression, scap elevation. You can call it what you want, but I was trying to release some of the congestion up there, assuming that was the issue. And that's what I did the last visit. And I think that was the last time I saw her. Let me just see. Yeah, that's the last time I saw her.
Mhm.
Okay. So, and she's coming in today, and I'm wondering, because I don't think, with this type of a patient, I do think she's brachial plexus. I do think she's got neural tension. There's something else going on, I
Right.
think. And I do agree with you, it's autonomic. And I'm wondering now what my progression should be or will be. I take that back. At the last visit, I did do some because I was trying to release some of the tension up in the scapula. I did do a taping just to unload the brachial plexus, scapula unloading. I can post
Mhm.
that up there. It's actually in my book. If anybody has my book, but I can show you. I have a picture of that I could post I could send
Mhm.
out to people.
Yeah.
Uh,
So my questions are, as you're kind of forward
yeah,
thinking now as to
yeah,
where to go and what to do, is um, sometimes you have to get people to calm down a little bit so you can get to the backstory, the real story.
yeah.
So she's 51. We're
Hmm.
suspecting some autonomic stuff. Does she have any other health markers that
No,
made you kind of be concerned
no, she's
with
pretty.
her at all?
No, I mean she's takes Wellbutrin like everybody else it seems, but other
Mm.
than that, that was her only. I mean that's pretty classic. No, no, I mean she's
No
eh,
diabetes, no metabolic
no,
disease,
nope. Her health
that
was
kind
pretty
of
good.
thing. Sometimes, and this may even sound a little bit far-fetched. I'm not reaching for the stars, but I'm just going to lay that out there gently, that we need to kind of also, kind of consider something a little more systemic with somebody like this. Season in her life, and she's shifting a little
Yes.
bit, and this is not an atypical presentation sometimes.
Uh,
There's real reasons why she's hurting. Don't get me wrong at all, everybody out there listening, but some of the underlying kinds of metabolic pieces could be playing 10%, 20%, something, and it just happened to, this is the area that was being overworked and overused and had been for so long, so it was the area that ended up being a little bit more inflamed than other
yeah,
areas. For
yeah,
somebody else, it could be heel pain. For somebody else, it could be, posterior knee pain, hip pain, maybe even back pain, just, neck pain, full on blown neck pain, rather than shoulder or, down this arm kind of thing a little bit. So I think those are all kind of good things to kind of begin to look at just a little bit there as well. And what's the quality of her sleep? Now that she's doing better, is she feeling as bad when she wakes up in the morning?
yeah. No, I'll ask her
Or
today. Yeah,
yeah, because I think
yeah,
it'd be interesting to know that, yeah, everything is better except when I get up in the morning. It's
yeah,
like, wonder what's really happening at nighttime. Are you really getting the kind of sleep that you're after?
yeah. It's funny you mentioned hormones because she is
Mm-hmm.
going through she is in probably
Mm-hmm.
perimenopause, and
Mm-hmm.
we started talking about hormones because I have going through that as well myself. So she, yeah, I mean we had a long chat about that the last
Mm-hmm.
visit. Actually, it's kind of funny you mentioned that, and I do think that is playing into it
Mm-hmm.
for sure.
Yeah, and the interesting thing about the hormones is that everybody wants to go straight to, is your progesterone too low? Is your estrogen, where are you with that? And I also kind of like to even take it even a step back. This is somebody you said works in the financial world, right?
Hmm. Yep.
So she probably has seasons of her life, and there's probably different kinds of things that may be happening at work, and maybe this is a full-blown stress response. We can handle adrenaline for the short term, but if we don't take care of it and change that response to adrenaline, it turns into a cortisol reaction.
Yeah. Yeah.
And, feeling bad in the morning when you get up, maybe that our cortisol is high, and that can wreak havoc on nerves, and it just happens to be that this is the most vulnerable place for her. It doesn't have to mean that it's full-blown nerves everywhere, but it could just be that this is where it's actually kind of presenting itself. So, so those things I think are important too, to kind of consider that life health balance. She sounds like somebody who's ready to listen and be part of that conversation now, because she's starting to change and improve, and she's starting to kind of feel good enough to say things to you like, okay, but now my neck, because before it was like, I'm just not better, so forget it. But now she's getting better enough. When people start complaining about other things, that's when you have them. It's like, okay, so this is no longer the big issue. Now we're really getting down into the what I call the needles in the dirt, the stuff that's on the ground. Okay, let's figure out what's going on here now, because the other was just that final end stage or further down the road, kicking the can down the road progression of something, and you're getting the arm so much better. It's like, okay, but where is this coming from? And I love the fact that you started at her thorax, and you're going to probably end up at her thorax.
Right. Well, it's interesting, that whole upper thoracic shift to the left, that could be playing into it. And she did mention at her first visit, actually, that she felt that stress was a big factor. Of course, I worked on Wall Street. I get it. It's stressful. And
anything that's going to be, we have timelines and deadlines is going to be stressful, for sure.
Yeah, and so I do think that's the issue. So then in terms of the thorax, I will go in there. Actually, I will, when I see her today, I will go in there and I'll see how she's doing and reassess a bit up there. In terms of any kind of neural glide progression, is there anything else that you think I should be doing there?
That's interesting, because I was just sitting here thinking about how would I progress this person, especially if compression was no bueno. I mean, you could put her arm on the wall instead of on the ground, and things like that, and limit the amount of wrist flexion that's going on. But what might be interesting is get her into, see if you can get her into, somewhat like modified long sitting to do her normal upper stuff that you already have her doing that she's good with, winding the system up from below, putting a trunk twist in it, seeing which one is going to really tension her up just a little bit more, because those are things she could do at her desk. She could bring her feet up and put them on a stool and pull her toes back. She could, put a rotation in her trunk as she's doing her waiter and, some of these other things to kind of progress it along, until that they can, as you're kind of working on the desensitization into compression, because you want her to have some, good things to do, but you don't want to take her into a full flare, right? I mean, it's kind of tricky when we're talking about nerves, we think how can I wind her up from below? And see if that begins to do something just a little bit. It takes me back to my one patient, I think we were talking about 2 or 3 podcasts ago, that was having the neural tension down in her calf and into her foot, ankle and foot region. And, we were even talking about her going upstairs because she would look down. But when, and it took me, and finally I just asked her to go into that, kind of, okay signal with your hand and put it over your eyes and lift your elbows up, the Junior Birdman thing, for those who know that. And she wasn't even hardly able to get her arms up in long sitting, get her arms up to
that's fantastic.
Remember?
Yep.
And it was like, woo, wow. And that was really telling to me. It was like the tension in her system was so profound everywhere. She was young enough and mobile enough to kind of bypass it most of the time, but not all of the time. And, treating that, so I would even kind of spend some time tensioning her up from her trunk or below, and you're going to go into the thorax anyway. Some good old fashioned breathing exercises and moving and, getting that trunk mobile is also going to be extremely helpful, because, she's a little bit at risk because of her dominant postural situation.
Yes. Yes.
that's something that's going to run afoul just because she's spending a lot of time. Doesn't really matter what it is, just for her, it happened to be her upper extremity. But,
Yep.
if you're in one posture all the time, it becomes problematic over the years.
Yeah, especially,
So,
yes, I agree. I think because she is, using that right arm for mousing, and she's using that every day.
mhm.
So I love that modified long sit. You've run it up from below. That's a great idea. And try, because I do think that because it's definitely been helping her, and uh, I need to sort of progress that. And I like the fact of winding it up from below and adding twists and things like that. She'll definitely do that.
Mhm.
I think sometimes that uh, we need to wind the whole system up. It's obviously not acutely, but this is a long time at this point.
Yeah,
It's
this
a long time.
is a persistent kind of
Yes,
situation here. Mhm.
yes, and so I think that's a great idea. And in terms of the thorax, I think that I'll probably just end up going in. I'm just looking at my notes here, and just assess a couple things in the upper thorax, and have her do a couple things that bother her to see if that does any kind, makes her better or gives her any kind of relief.
I would look for the stiff drivers in the thorax. Where is
Yeah.
she stiff?
Yep.
Where is she not
Yep.
moving well? Mhm.
Yep. Yep. Exactly. So that's what I'll do today. I mean, in terms of her range of motion or thoracic rotation, I checked last time, it's pretty good, but that's not
Mhm.
really that's actually even better because I can wind her up in a long sit position and have
Yeah, it'll be interesting
thoracic
to see what
rotation.
happens and how that changes the range of motion and everything up the chain.
Yep. I think for me, that's where I'm at. I mean, I really wanted just to sort of get an idea of how to progress and what to do, and sort of give everybody a really interesting patient, because this is, I mean, people don't come in with acute elbow pain. They wait
No.
forever, I mean, seriously. Everybody's doing the wrist exercises. I mean, it's just not helping at this point.
Mhm.
I mean, not that everybody, some people it does help, but with someone with this presentation, like, especially when they're taking their arms and their hands and they're picking apart their arm. I mean, that's not normal for elbow pain. It's just not. And so for me, I put that the first thing was brachial plexus and nerve. So one thing I want to just do is to keep decompressing her and not have her compress into that brachial plexus.
Yeah, I would agree. Certain amount of stress you want to take the system through, and there's a certain amount that you just don't want to. And it's a fine line, right?
Yeah. Yeah.
It's a fine line about how much is too much and how much isn't enough. And I think you've kind of hit the sweet spot, which is why you're trying to back away from the closed chain stuff a little bit, because it was something that made you feel like, oh, this is taking her too far down the edge. So
yeah, when I had her do it, I'm like, I don't know. It's like when you, as a clinician, you're like, I don't know if that's going to work. Then I just don't give it, because I can't supervise the person at home. So
yeah, exactly.
I think that's pretty much it for her. I mean, really, I think I've got the plan. I was definitely going down the thoracic. I think she's got multiple things. I do think her hormones are a problem. Her stress is a problem. Her autonomics, I do, and neurotension. So it's never just one thing with these people. It's always like 4 or 5 things. So I think that's it for me.
That's fantastic. Great story.
Yeah, we'll see. I will. I know we keep promising to update on patients, but we will definitely do that.
Yes. We have a plan for that this quarter, so we will make that happen.
Mm-hmm. And if anybody, I always say, if anybody has any questions, contact us. Feel free on social media or here. If you want me to post that scapular taping, I can certainly do that on our website. And that's it. We're good. Cool.
You're good. Thank you, everybody, for listening. From out west for myself and back east for Erica. We appreciate it. Leave us your comments, fill out reviews, and keep us going. We enjoy this, and we hope that you're getting a lot out of it as well. Thank you.
Sounds good. All right. Bye, everybody.